इंट्रोडक्शन कैसे स्टार्ट करना?
सर आप कर दो, आई थिक दैट
मैम को बोलो, मैम इंट्रोडक्शन स्टार्ट कर देती, मैं चैप्टर स्टार्ट कर देता हूँ.
चलो
एंड
ठीक है,
मैम विल फिनिश द चैप्टर. ठीक है?
ठीक है, डन.
Okay. Ma'am, we have to see that what questions were asked in last 5 years exams. INI-CET में, NEET, PG में, FMG में. And ma'am, you tell us that what you have included.
मेरे तो students always have a problem with the pink and blue. That is what my subject is known for, which I think आप भी cover करोगे. So mainly from my domain, it will be histopathology and वो molecular classification. Let's start. Hi everyone, I'm Dr. Preeti Sharma, your pathology and microbiology faculty at PrepLadder, and with me I have Dr. Pritesh Singh Sir, the surgery faculty at PrepLadder, and together we are going to take a very important topic for you today, that is breast cancer. A topic which you've often studied more in surgery, but there was a gap which we need to address, and that is how to integrate it with pathology. Because somewhere in day-to-day practice, this is a subject where the surgeon and pathologist are constantly in touch with each other. So we just don't want to prepare you for your MCQs, but also for your day-to-day practice. So thank you, sir, for joining, and let's start with the session.
Okay, guys, so let's start straight away. Breast cancer, first of all, we are going to discuss the risk factors. Can you tell me what are the risk factors? You know that breast is a gland and the malignancy arising is adenocarcinoma. And for adenocarcinoma, you must be knowing that high socioeconomic status means is a risk factor. So adenocarcinomas are more common in high socioeconomic status. So here you are going to notice that risk factors are revolving around high socioeconomic status. So you can see here, what is the risk factor? First is advancing age. Second, origin. So the female should be belonging to Western countries. So what? Western countries. Clear? And high socioeconomic status, that is the risk factor. And you know that females belonging to high socioeconomic status, usually they take alcohol. So alcohol intake. High fat diet, obviously high fat diet, it will lead to obesity. So there is another risk factor, right? Next, state of hyperestrogenemia. You know that estrogen is having positive effect on breast cancer cells. So state of hyperestrogenemia is the risk factor. And what are the states of hyperestrogenemia you must be knowing? Early menarche, late menopause, nulliparity, late first full-term pregnancy. So these are the states of hyperestrogenemia. Early menarche, that's early menarche, clear? Late menopause, nulliparity, it's nulliparity, and late first full-term pregnancy, clear? So there is late age, late first full-term pregnancy, right? These are the states of hyperestrogenemia. Next, positive family history. You must be knowing that both paternal as well as maternal, history is significant, but mainly it's the maternal side which is more important. Maternal, it means patient's sister, patient mother, and patient mother's mother. You know, if she is having breast cancer, it means the malignancy is running in the family line. Next, personal history of malignancy. Can you tell me what are those malignancies which are adenocarcinoma and common in females? Yes, ovarian cancer, endometrial cancer. So personal history of malignancy, which one? Ovarian cancer. It's ovarian cancer and endometrial cancer. So ovarian cancer and endometrial cancer. After that, genetic mutation, and you know the most important genetic mutations are BRCA, BRCA1, BRCA2, and guys, you must be knowing both BRCA1 as well as BRCA2, both of these are responsible for breast cancer in both males and females. BRCA1 mainly in females and BRCA2 mainly in males. BRCA2 mainly in males. So how to remember? You must be knowing the mnemonic, ladies first. So the mnemonic is, guys, it is ladies first, right? Next, hormone replacement therapy. This is the risk factor, and most important, one of the most important risk factor, history of therapeutic radiation exposure. Guys, how much radiation exposure? The amount of radiation which we give in malignancies, it is 40 to 60 gray. Can you tell me how much is our body tolerance limit? Usually it is 60 gray. So in your lifetime, you should not receive more than 60 gray. It is a risk factor, right? So these are the risk factors. After that, you know, smoking tendency is increasing in females worldwide, especially in India. And because of that, guys, what's the big problem? Smoking related conditions are also increasing. Smoking is a risk factor for CA breast. It's a risk factor for duct ectasia. It's a risk factor for Mondus disease. You know what is Mondus disease? Superficial thrombophlebitis of inframammary veins, and Zuska's disease. This is also known as recurrent periductal mastitis. So smoking increases the risk of these conditions. Easy? Now guys, the pathology part, especially the gene mutations and the tumors, will be discussed by Dr. Preeti. So ma'am, over to you please.
So as sir rightly said right now, that genetic factors play a very important role in breast cancer, and sir has already told us about BRCA1 and BRCA2, and I've also learned the ladies first mnemonic, which I think I'm going to incorporate in my video lectures going forward. So as sir told us, BRCA1 gene not only for breast cancer but also for ovarian cancer, both BRCA1 and 2 are important. BRCA2 particularly important for male breast cancer, and let's integrate it over here because on male breast cancer you have very few questions but are important. So one could obviously be associated with the BRCA2 gene mutation, and there's a genetic disorder with which it is also associated, and that is Klinefelter syndrome. Questions are asked in the exam as well. Now, when we talk about their chromosomes, BRCA1 gene is to do with chromosome number 17 and BRCA2 gene is to do with chromosome number 13. Let's look at all the other genes. You've understood the most common, but this is the most common when we are talking about familial breast cancer. It's not that every breast cancer runs in the family, as sir has just told us the risk factors, right? There are some breast cancers which could be sporadic also. So when we talk about the genetics, which is the most common sporadic gene, that is going to be P53. But if P53, either it could be sporadic or it could be running in the families, and when it runs as a mutation in the family, it causes the famous leave from any syndrome. I mean, this is a question known by all students, that this is the policeman of the genome. If this is mutated, it results in leave from any syndrome. And how do I pick up that a family has leave from any syndrome? I'm going to look out for the BB tumor. So if they come to me with a history where in the family there are blood cancers, there are brain tumors, there are breast cancer like this patient, and bone cancer. So if these are the kind of tumors running in the family, then I will be thinking of the leave from any syndrome. The next gene which we have is P10, which I think is known to all students, that the chromosome name is written right there. So that is present on chromosome 10, and the syndrome with which it is associated is Cow-Den syndrome, and this is also resulting in breast cancer. Let's move on to the next. We come down to all rarer causes, but since this is a table which has recently been added in Robbins, it becomes important for you. STK11, well, when you teach this, and sir also must have taught you in GIT, this is to do with Peutz-Jeghers polyps and syndrome, but that can also result in breast cancer. Then we have CDH1, which all of you famously known as CDH, being the short form for CDH, that is E-cadherin. So if CDH is mutated, the E-cadherin will be lost, and that is something related to a breast cancer, that is invasive lobular carcinoma, which we will be talking about in a while. Then let's come to the newer marker, and anyone who's targeting the upcoming May INI-CET, remember PALB2 has been added in the previous edition of Robbins. This is a marker or a gene which is mutated not just in breast cancer but also in many other tumors. So like the PALB2 gene is red, you know all the tumors with it. So number one, it is associated with prostate cancer. This has been associated with pancreatic cancer, and it has been associated with breast cancer also. So this is a new gene added. And another question which would be expected again in INI-CET is that all of you, like sir recently told us, that radiation is a very important risk factor, right? So radiation causes mutation of which gene? And that is going to be the CHEK2 gene. So this could be one of the questions that is probably coming up to you, that radiation-induced breast cancer is associated with which genetic alteration? That is CHEK2. Also for students, and I'm particularly telling extra pointers for INI-CET because that's the exam closest to us. So if you get a question on this new gene by chance, PALB2, I've already told you what are the different tumors that can occur with it. But do you know that these tumors will occur when only one allele of this gene is lost? Because what if they ask you that both the alleles of this gene is lost? What would I call it? Biallelic loss. If both the alleles are lost, that is a complete bone marrow failure, and that would be resulting in Fanconi's anemia. So repeating the monoallelic loss will lead to these cancers, whereas the biallelic loss will lead to Fanconi's anemia. So that's a wrap up on all the genetics. And I think now we are ready to discuss breast cancer in more detail. So sir, over to you.
So guys, we are going to discuss now the one-liner questions which are asked frequently. We discussed already that what is the most common histological type. This is adenocarcinoma, and you know that subtype is invasive ductal cancer. So most common histological type, that is adenocarcinoma. It is adenocarcinoma. And the most common subtype, that is invasive ductal cancer. It is invasive ductal cancer. Previously, examiners were asking what most common subtypes, but nowadays they are asking least common types also. So can you tell me what is the least common subtype? Yes, you know what is the most common type of thyroid malignancy? Papillary. So thyroid का जो best है, yes, breast का वो least है. So you know what, in thyroid malignancy the most common type is papillary. In breast the least common type is papillary. So guys, here least common type, this is papillary. So it's easy to remember. Thyroid most common, papillary. Breast least common is papillary. Next, which type is most malignant, having worse prognosis? You already know. This is inflammatory breast cancer. And this was asked in NEET PG. Least malignant, having best prognosis. And guys, this is tubular. So least malignant, having best prognosis, that is tubular. Next question, that breast cancer is most common in which breast? Obviously left breast. And in left breast, which quadrant? You know, upper outer quadrant. Can you tell me why breast cancer is most common in upper outer quadrant, guys? Tell me. It is most common in upper outer quadrant because there is maximum amount of breast tissue in upper outer quadrant. So similarly, what is the least common site? And you know, the least common site, it is lower inner. So most common site, upper outer. Least common site, that is lower inner. These are the one-liner questions. After that, what is the route of spread? You know, there are carcinomas, there are sarcomas. In sarcomas, exclusively there are hematogenous spread. There are certain sarcomas which are having exceptions, but in carcinoma, there can be hematogenous as well as lymphatic spread. If a malignancy is arising from gland, usually adenocarcinoma, so here the most common route of spread is lymphatic. So in breast cancer, both lymphatic as well as hematogenous spread is there. But guys, the most common route of spread, you know, it is lymphatic. This is lymphatic. Next, what is the most common site of metastasis? Let me tell you, in body, metastasis mainly goes to 4 organs. How to remember? LLBB. LL means liver, lungs. BB means brain, bone. So here, it mainly goes to bone. Can you tell me, guys, which bone? And you know, there is a mnemonic. Mnemonic is what? LFT. So which bone? It is LFT. So you know that it is lumbar vertebra, followed by femur, followed by thoracic vertebra. Lumbar vertebra, followed by femur, followed by thoracic vertebra. Next, we discussed LLBB. So in LLBB, death mainly occurs from LLB. LLB means liver, lungs, brain. Let me tell you, from bone metastasis, usually death doesn't occur. And anybody who is having bone metastasis, maximum that person is having what? Backache. There might be compression of nerves. So that person might be having pain, paresthesia. Death usually doesn't occur. So can you tell me what is the most common cause of death? See, breast is here. So you can easily understand breast. So obviously it is involving which organ? Lungs. So in lungs, guys, the most common cause of death, it is malignant pleural effusion. So guys, here the most common cause of death, that is malignant. This is malignant pleural effusion. It is malignant pleural effusion. Easy. In INI-CET and NEET PG, multiple questions were asked in relation to pathway of spread. So see how it is going to spread. Breast cancer cells, you know that the most common site is this upper outer quadrant. So there is involvement of posterior intercostal vein. And after posterior intercostal vein, it is going to Batson plexus. And via Batson plexus, you guys can see, via Batson plexus, it is going to, you can see, it is going to lumbar vertebra. Right? After that, it is going to dural venous sinuses. You know that in Batson plexus as well as in dural venous sinuses, there are no valves. What will happen? From dural venous sinuses, it is going to leptomeninges, and from leptomeninges, brain. So these are the questions which are asked in relation to pathway of spread. After that, see what? The features of breast cancer, presentation. So guys, majority of patients who are having breast cancer, they belong to high socioeconomic status. And the females who are belonging to high socioeconomic status, the moment they are going to notice any kind of lump, immediately they present. So what happens? If this female is having any kind of lump, she will come a bit early. But what happens in rural area, females are not very educated. Second, they have stigma also. So that's why what happens, until and unless malignancy is very advanced, they are not coming to you. So what will happen over a period of time? First, the most common presentation, that is lump. Easy. But whenever size of lump will keep on increasing, what will happen in the breast? Tell me. Yes, the shape of breast is going to change. And if the shape is going to change, there is architectural distortion. After some time, what happens? The both breasts are not looking similar. And if both breasts are not looking similar, guys, there is asymmetry. Next, what will happen? Malignancy, it is going to involve skin, it is going to involve nipple, it is going to involve the chest wall. So whenever there is involvement of skin, what will happen? Skin fixity. Whenever there is involvement of chest wall, fixity to chest wall. And if there is involvement of nipple, you know guys, if nipple is involved, there is retraction, deviation, ulceration. So there is retraction, you can see, retraction, deviation and ulceration, deviation and ulceration. Okay. After this, what happens? After this, actually patient is having metastasis. Now see, if patient is having metastasis to bone, lumbar vertebra, what happens? Backache. Metastasis to brain, headache. Metastasis to lungs, patients are having dyspnea. Metastasis to liver, what? Jaundice. And over a period of time, because of cachexia, these patients are having anorexia and weight loss. So what will happen over a period of time? Patients are having anorexia and weight loss. Anorexia and weight loss. So these are the manifestations. After that, the questions which are asked nowadays, these are mainly related to image-based question, and you must be knowing, especially NEET, PG, INI-CET as well as FMG. T4B, that is pure orange. T4D, that is inflammatory breast cancer. These are frequently asked. Can you see this image? Guys, can you see what's happening here? This patient is having nipple retraction. So this is retracted nipple. Now see the next slide. In this case, this is the question. 100% chances are there that you are going to get this question in the next exam. You can see it is pure orange. And guys, can you tell me what is the cause of pure orange? You can see this is lymphatics. Yes, in the breast skin, whenever there is lymphatic permeation by tumor cells, means the tumor cells are going to obstruct the lymphatics. So if tumor cells are going to obstruct the lymphatics, what will happen? Cutaneous edema. And this cutaneous edema, this is pure orange. This question was asked in INI-CET long back. What was the question? What is the most conspicuous or most obvious sign of breast cancer? Means just by looking at the breast, you can tell the patient that you are having breast cancer. Most conspicuous or most obvious sign, it is pure orange. Another thing, dimpling. What is dimpling? You must have seen dimples. So skin depression, you can see here, patient is having dimpling, skin depression. There is another change, guys, puckering. What is puckering? You can notice here that this patient is having wrinkling in the breast skin. So dimpling and puckering, both of these are involvement of ligament of Cooper. Remember, both of these are because of involvement of ligament of Cooper, dimpling and puckering. You can see this change. Can you see, guys? This is cancer in cuirass. You can see multiple nodules here, multiple nodules, ulceration involving breast skin and chest wall. So this is cancer in cuirass. I'm repeating again, which question will be asked in exam? Most probably you're going to get pure orange. So these are the signs. After that, any patient who is coming to us, what we do? Clinical history, examination. We send the patient for investigation. Can you tell me the first investigation done? Mammography. Sometimes we send the patient for ultrasound also and confirm it by biopsy or FNAC. So guys, this is known as triple assessment, and you can see what are the components of triple assessment. Clinical, signs and symptoms. So clinical, signs and symptoms. Clear? Imaging. In imaging, we are going for MRI, mammography, and we are going for ultrasound here. And tissue sampling, we are going for biopsy and FNAC. The question which is asked frequently, that how much is the positive predictive value of triple assessment? It is almost 100%. Guys, this is 99.9%. So this is 99.9%. We already discussed what is the first investigation done in a suspected case of breast cancer. That is mammography. So this is mammography, and you know that investigation of choice for diagnosis of breast cancer, biopsy, and what are the other names of biopsy? True cut biopsy, core cut biopsy, needle biopsy. Easy? Next, mammography, one of the frequently asked question almost every year. So guys, you know that it is investigation of choice for screening of breast cancer. Can you tell me at what age screening should be started? It should be done in all the females started at the age 45 years. Started at the age 45 years. What is mammography, guys? Mammography, nothing. It is X-ray of breast. Only changes that the dose and orientation is different. That's it. So what kind of X-ray we are using? We are using Brehm straw lung. What's the name? It is Brehm straw lung X-ray. How much is the radiation exposure? Tell me. One of the favorite question of INI-CET people. It is 0.1 centigrade per study. So 0.1 centigrade per study. So one mammography is equal to how many chest X-ray? Tell me. One mammography is equal to 4 chest X-ray. It equals to 4 chest X-ray. So this is mammography. Now see, what are the findings in mammography? Guys, whenever you see mammography, first thing you have to see is nipple. Notice the nipple, whether it's normal or it's retracted. In this case, you can see it's retracted. Second thing, what you have to see, yes, opacity, whether this is having regular margin or irregular margin. Third thing, you can see this kind of calcification. What is this calcification? Microcalcification. There might be skin thickening, and behind breast, which muscle is there? Pectoralis major. Behind breast, in between breast and pectoralis major, there is a space. What's the space, guys? Retromammary space. So there is obliteration of retromammary space. So these are the findings which are seen in breast cancer. Now see the findings of benign conditions like fibroadenoma. Here you can see normal nipple. Here you can see popcorn calcification, which is the characteristic feature. Opacity is having smooth regular margin. So you want to see the differences. See the differences between benign disorders and malignant. Benign, smooth, regular margin. Here, irregular margin. And can you tell me, there are 3 words which are asked in exam. Examiners are giving one of these 3 words, and this is suggestive of malignancy. What are those 3 words? Stellate, speculate, comet tail. Remember, the words stellate, speculate, comet tail. So stellate, speculate, comet tail margin. Clear? Remember, guys, these words. Comet tail margin. Rest of the things is easy to remember. Homogeneous. So here it is heterogeneous. Low density. Here there is high density. What do you mean by low density? Low density means the density is very similar to normal breast tissue. High density means the lesion is having higher density. Thin halo. Halo means empty area around the tumor. Here there is wide halo. Its malignancies are having wide halo. Calcification, you know, what kind of calcification is seen in benign conditions? Macro. Macro calcification, and guys, you have to tell me the size. Macro calcification size more than 0.5 mm and microcalcification less than 0.5 mm. Clear? There are associated changes in malignancy only. We discussed skin thickening, obliteration of retromammary space. So guys, here skin thickening, obliteration of retromammary space. So retromammary space obliteration, and what else? Nipple retraction. You are going to notice nipple retraction. Easy. These are the differences between benign and malignant lesions. I'm telling you the question also. High chances are there that if mammography film will be given in the exam, they are going to ask you malignancy only, because popcorn calcification is very, very easy. Okay. Now you know that we are going to assess one score on mammography. If you have seen mammography report, in mammography report it is mentioned the score, that is BIRADS. What's the full form? Breast Imaging Reporting and Data System. If the score is 0, incomplete assessment. If it's 1, it's negative. If it's 2, it's benign. Okay. Whenever it's negative or benign, obviously annual mammography is recommended. Means you ask patient to come next year. Annual mammography is recommended. But whenever it's probably benign, the score is 3. You are not 100% sure. That's why this patient should come in OPD. So what? Go for short-term follow-up. So we go for short-term follow-up. Category 4 is suspicious. There can be low suspicion, moderate suspicion, high suspicion. Whenever you have any kind of suspicion, confirm. How? Biopsy. And if it's category 5, it is highly suggestive of malignancy. Category 6, biopsy proven malignancy. So guys, can you tell me the risk of malignancy? Risk of malignancy. Incomplete assessment, so it's not applicable here. Category 1 and 2, obviously it's 0% because it's benign or negative. Category 3, it's more than 0 to 2%. 4A, low suspicion. 4B, moderate suspicion. 4C, high suspicion. So in guys 4A, it is more than 2 to 10. In 4B, it is 10 to 50. 10 to 50%, and in 4C it is more than 50 to 95%, and if it is category 5 it is more than 95%, and category 6 you already know, it is biopsy proven malignancy. We are expecting one question out of this by red score. Okay, next, suppose a patient is having family history of breast cancer just like Angelina Jolie, or she's having BRCA mutation just like Angelina Jolie. It means any female having positive family history or genetic mutation, she's high risk. And in such females, we are going for a better investigation than mammography having higher sensitivity. And all of you know which one is having higher sensitivity? MRI. So investigation of choice for screening of breast cancer in high risk females. Guys, in high risk females, it is MRI. Another indication of MRI, some females are going to use breast implants like silicone implants. So whenever there is implant related complication, we are using MRI. So for the diagnosis of implant related complications. Easy? Implant related complications. Implant related complications. And next, investigation of choice to differentiate benign lesions from scar. Differentiate benign lesions. So benign lesions from scar. From scar, we are going for MRI, obviously. Next, you know, mammography, it is not very sensitive for young females. Why? Because young females are having dense and glandular breast. And that's why if you see mammography of young females, most of the areas are black. So what is the first investigation in young female age less than 35 plus she is having a lump? Young female age less than 35 plus female having lump. And you know PET scan, positron emission tomography. Here it is used mainly for the diagnosis of metastasis, oblique malignancy, mainly the metastasis. And imagine you perform the surgery for breast cancer. Patient comes to you after 6 months saying that, sir, at the site of surgery, I can feel a nodule. You can also feel the nodule. You are not 100% sure whether this is a scar, it is fibrosis, scarring, or it's a recurrence. So obviously to differentiate recurrence from scarring, fibrosis, necrosis. From scarring, fibrosis, necrosis. Clear? So from scarring, fibrosis, necrosis, we are going for PET scan. PET scan. And you know, if there is bone metastasis, we are going for bone scan. So bone scan, if there is metastasis to bone. So guys, these are the investigations, right? Next, hand over to ma'am, please. She will discuss the tumor and the microscopy.
So as sir just described all the radiological investigations to us, it also gave me a lot of nostalgia because one by one यही वो सारे questions थे sir जो second prof में, because I got a long question on this case and one after the other starting from triple assessment to all the mammo findings. This is exactly what we were asked, especially the dimpling and the पौधे orange appearance, and back in the day ये सबसे मुश्किल questions लगते थे, but now I think I wish I would have had this app and this session. We would have known answers to them which we were struggling for otherwise. But now taking you a little away from surgery and going into pathology, as sir said that we are ultimately, after all these, we are going to go in for a biopsy or an investigation which will require histopathology. So I've made a table for you which will summarize all the histopathology findings. I'm going to deal with it one by one, starting first not with the cancer but a precancerous condition, and we'll zoom into it, and that is known as ductal carcinoma in situ. Now as soon as the word in situ comes up, you know that I'm dealing with something which is precancerous, and whenever I say precancerous, the basement membrane over here is intact. So there are many types, and I don't want you to go into that extreme detail, but I want you to learn two types which are often asked in the exam. One is the comedo type of DCIS. What is comedo? You must have read in dermatology, a comedon, like an acne, if you press it and some dirty material comes out of it. Same way, when I say comedo, it means there is comedo necrosis. So if I zoom into this, you will see that particular gland, but in the center of it, there is some dirty material present, and this is the necrosis. If I press, this dirty material will come out, and that is why it's comedon necrosis. necrosis has happened, it's a kind of a cell death. So your basic general pathology tells you that this is going to be a type of a high-grade DCIS. Moving on to the next variety, that is cribriform. Cribriform, in simple words, it's known as a sieve, and in Hindi it's called as channi, right? So this is going to have those small holes in between. As similar to that, when we look at this duct under the microscope, you will notice it has those small spaces, and that is why we call it the cribriform type of DCIS. So this is keeping in mind that in both of these, the basement membrane needs to be intact. Having done the first one, now let's go on to, as sir told us, the IDC is the most common type. So invasive ductal carcinoma, but right now I'm not talking about the special types. I'm talking about the generic, not otherwise specified IDC, which is going to be very similar. And as we did the first line of this particular session, was that it's a type of an adenocarcinoma. So adenocarcinoma will always have glands, and this is exactly how it looks like. Let's go one by one. When I look at it grossly, you can notice that this is an MRM specimen. You can see how one slice of the breast has been cut, and we have this gray tumor, but it's very poorly defined because see, it's a cancer, so it's infiltrating. You can see these projections going into the surrounding fat. So while sir will gradually tell you about the TNM staging, how the size of the tumor matters, it matters to us also in pathology. But for us, what's equally important is what is the status of these margins. And that is the report which I think the sir would agree with me that the surgeon is also waiting for, that what is the margin status, because the future therapy so much so depends a lot on this. So while we are assessing the tumor over here in the center, we are also inking and knowing what the margin status is. And giving a negative margin status is so much, it brings a lot of happiness not only to the patient but to the surgeon and to the pathologist. Now when you cut it, because I'm cutting this with a scalpel, right? So the feel that I'll get while cutting this is very gritty, as if I'm trying to cut something like chalk. Reason being that, as sir was telling us about calcification, so you realize that whatever you were seeing in your radiology corresponds and correlates very well with the pathology part. And of course, when I look at it under the microscope, it's an adenocarcinoma. I can see a lot of glandular formation, which kind of makes sense along with invasion because it's a cancer. But that is going to be the not otherwise specified. If I now go into subtypes, the first one that I have is tubular. No one is going to give you a picture of tubular carcinoma, but it's pretty common sense that you will see these round tubules. And as sir told us, this is one of the subtypes which is going to have a good prognosis. In fact, one of the best. Gradually, we will talk about hormone receptor status also. So this is the one which is going to be in the good category eventually. Moving on to the next, mucinous. This is going to get you a lot of pictures. So let me show it to you right away. When I say mucinous carcinoma, what's kind of making sense to me over here is that there's going to be a lot of mucin. So first, before I go to the resection, the biopsy, we do an FNSE, right? If I put a needle inside a mucinous carcinoma, I'm expecting I'm going to get a lot of mucin. So much so we call it pools of mucin. So I'm not expecting too many cells to come out in my FNSE needle. I'm expecting too much of pool of mucin to come out. So much so that as I zoom into this picture, I notice all these blood vessels get entangled in that mucin. And this is known as the chicken wire blood vessel appearance seen on FNSE. Repeating, chicken wire blood vessel on FNSE. Now, when we do a resection or a biopsy, I can look at this picture and most of it looks empty because again, these are pools of mucin. So where are the cancer cells? These small islands which are floating in those pools, these are all the tumor cells. So together we define it as tumor cells in pools of mucin. Now please note, most when I say mucinous carcinoma, it has a misnomer and it is also known as colloid carcinoma, whereas it has nothing to do with the colloid of thyroid. It's just a misnomer. But usually you get a question, and let me teach that to you first, which says, if you get a question of a 30-year-old, a rather young female with a 4 centimeter mass, the biopsy is going to show densely packed cells with bland nuclei and mucin infiltrating the stroma. So when I say mucin infiltrating the stroma, I understand they're talking about mucinous, but that is not written. So I go for its misnomer, and that is colloid carcinoma. But understand, with so much of mucin, the overall consistency, or when you palpate this, it is not going to be extremely hard like usually cancers are. It is going to get a little firm or a softer consistency. Reason being, the mucin is going to make it a little softer in comparison to the other cancers. Let's move on. So after mucinous carcinoma, I can see the next tumor coming up, and that is medullary carcinoma. This is also something which I will gradually tell you as we discuss the hormone status, that this comes under the triple negative breast cancer. And despite all features which I know as a pathologist, I understand, but as undergrad students, you don't understand so many nucleoli findings. So what is the finding that you have to learn for the exam under this is the prominent lymphoplasmacytic infiltrate. And there are precisely two tumors in the entire pathology where I want you to learn this. If they tell you about breast cancer, which shows you lots of lymphocytes and plasma cells, it is medullary carcinoma breast. If they ask you name a genital or a reproductive organ tumor where you see a lot of lymphocytes and plasma cells, so if they're asking about testes, it is seminoma, and if they're asking about ovaries, it is dysgerminoma. Moving on to the next one, that is inflammatory carcinoma, which sir was rightly telling us right now, which is to do with the Podé orange appearance, and you can see that classical finding. They, in fact, as we were discussing, there is a previous year question also, sir, as you was telling us about why does this come, and it is the subdermal lymphatics, which I think very recently was asked also in the NEET PG, right? Next, moving on to the secretory carcinoma, metaplastic carcinoma, which are just names that you have to know. Apocrine carcinoma, what are these subtypes of? All of these come under subtypes of IDC only. Because now after ductal, we are going on to the last category, and that is lobular carcinoma. Invasive lobular carcinoma, go back. The first slide of genetics that I taught you, I gave you a separate gene that this is a loss of E cadherin, and from E cadherin, we made the CDH1 gene. Now, another integration with surgery and medicine that comes over here, that whenever there is loss of E cadherin gene and they ask you which breast cancer occurs, it is invasive lobular carcinoma. If they ask you which is the stomach cancer that can occur, and that is diffuse gastric cancer, which all of us know as Lineitis plastica, so that also has loss of E cadherin. Of course, now we are left with how does this look under the microscope. So just like army men are very disciplined and they stand one behind the other right in a straight line, similarly, these cancer cells are also standing one behind the other in an Indian file pattern. I think this is something you can visualize even without zooming in, because it kind of stares at you once you're looking at it in the exam. So this Indian file pattern will be something which will help you a lot in invasive lobular carcinoma. Based on all of this, if we go ahead with a question which says what is the likely diagnosis of a 57-year-old woman presenting with left breast pain and redness, and there is swollen tender erythematous and a Podé orange appearance. So you realize that the starting sounded very much like an inflammatory condition, but the Podé orange appearance has ultimately come down to a classical inflammatory carcinoma, which we have marked over here. And if they asked me as a layer 2 question, they would have asked me about the subdermal lymphatics into which the infiltration occurs and results in this appearance. So that's all that you have to know with regard to the summary that I've got you. I think this is your go-to table before the exam. Apart from this, once I'm done giving this diagnosis, there are two more things I write in my report. One is the Bloom-Richardson scoring, which we will come to in a while. And I also give the hormone status. So, sir, first let's talk about the management and extra points of surgery. Then we'll come back to the hormone status after that.
Guys, nowadays lots of questions are asked in relation to TNM classification. So see the types of TNM classification. What is CTNM? The kind of staging we do in the wards in the OPD. So it's clinical staging. So obviously prefix is C. It is clinical staging. P, whenever we remove the specimen, we send the specimen to pathology, and it is pathological staging. So it is PTNM, it is pathological staging. PTNM, that is pathological staging. Suppose you remove the tumor and again there is recurrence, and then you are doing the staging, that is RTNM. So this RTNM, this is for recurrent tumors, right? So RTNM, this is for recurrent tumors. Recurrent tumors, suppose some patient is having multiple tumors and you have to do the staging. This is MTNM. M, that is for multiple tumors. So MTNM, this is for multiple tumors. What about Y? Y you have to remember, because rest are just prefix. C clinical, P pathological, R recurrent, M multiple. Why you have to remember? Because YTNM, whenever you give neoadjuvant chemotherapy and after that you are performing the staging, it is YTNM. So here, staging after. In this case, staging is done after neoadjuvant chemotherapy. It is done after neoadjuvant chemotherapy, and you can see here YPTNM, YP. So P means pathological staging, and what kind of staging? It's done after neoadjuvant chemotherapy. So guys, this is pathological staging. It is pathological staging done after after neoadjuvant chemotherapy. So pathological staging done after neoadjuvant chemotherapy. I'm repeating: C clinical, P pathological, R recurrent, M multiple. What you have to remember? Y and YP. So this is TNM classification. And remember, out of all 19 subjects, the most important topic is breast. And in breast, the most important topic is staging, because every year there is one question. And I'm telling you the question also, same. Puree orange, and the second is inflammatory breast cancer. So guys, see the staging. T1, the size of tumor should be up to 2 centimeter. It is not less than 2, it is up to. And T2, it's more than 2 to 5 centimeter. And T3, it's more than 5 centimeter. T4A, there is extension to chest wall. Let me tell you, pectoralis major and pectoralis minor is not the part of chest wall. Chest wall, it is formed by ribs, you know, it is formed by ribs plus intercostal muscles plus serratus anterior. Serratus anterior. So I'm telling you one important point in breast: involvement of nipple, involvement of dermis, involvement of pectoralis major, pectoralis minor. It's not going to affect the stage. नेक्स्ट T4B. सो हाउ टू रिमेंबर गाइस? 4A, A मतलब अंदर, तो ब्रेस्ट के अंदर का पार्ट अगर इन्वॉल्व हो गया, दिस इज T4A. अंदर मीन्स चेस्ट वॉल. T4B, B मीन्स बाहर. सो ब्रेस्ट के बाहर का पार्ट इन्वॉल्व हो गया, दैट इज स्किन चेंजेस. सो व्हाट आर द चेंजेस इन द स्किन? ऑब्वियसली देयर कैन बी edema including puree orange. So edema including puree orange. Clear? There can be ulceration and satellite nodules. Ulceration or satellite nodules. Satellite nodules. That is T4B. T4B. What is T4C? If patient is having both T4A plus T4B, मतलब अंदर बाहर दोनों involve हो गया, that is T4C. And the most important, it is T4D. And what is T4D? This is inflammatory breast cancer. This is T. Now see the lymph node staging. Whenever there is metastasis to ipsilateral axillary lymph node, which level? 1 and 2. And what kind of lymph node should be there, guys? It should be mobile. Mobile whenever it is matted. It is matted. So whenever involvement of level 1 and 2, ipsilateral axillary lymph node, level 1 and 2, it's matted or fixed, that's N2A. What is N2B? Whenever there is clinically apparent internal mammary nodes. What is N3A? Here, involvement of ipsilateral infraclavicular lymph node. Clavicle, infraclavicular. And if it is N3B, here there is involvement of ipsilateral axillary plus internal mammary nodes. So axillary plus internal mammary nodes. And obviously what is N3C? Whenever there is involvement of supraclavicular, ipsilateral supraclavicular lymph node. Most easiest is metastasis. So M0, there is no metastasis, and M1 means patient is having distant metastasis. There is distant metastasis. So this is TNM classification. You have to remember the TNM staging also. It's very easy to remember, guys. So you can see what is stage 1? It's T1. What is stage 2A? It is T021N1, and this is T2. What is 2B? It is T2N1. T3. What is 3A? It is T022N2 and T3N1 to 2. What is stage 3B? It is T4N0 to 2. What is 3C? It is TNE N3, and obviously stage 4 is TNE NNE M1. It's TNE NNE M1. So it's very, very easy to remember. Let me tell you the trick. What is the trick, guys? First, remember these highlighted stages. What are the highlighted stages? You can see M1, N3, T4. If it's M1, it's stage 4. If it's N3, it is 3C. If it's T4, it is 3B. बाकी को याद करने का आसान तरीका क्या है? What's the easy thing to remember, guys? Stage 1, number 1, 2A is 2, 2B is 3, and 3 is 4. What is this 1, 2, 3, 4? Can you see? 1. This is 1 plus 1, 2. This is 2 plus 1, 3. This is 2 plus 2, 3 plus 1. This is 4. Clear? So how to remember? Let me tell you. For T1, means for stage 1, number is 1. Suppose the size of tumor is 2 centimeter. It is T1. What is the stage, guys? It's 1. Suppose apart from this lesion, patient is having axillary mobile lymph node level 1 and 2. So if it's axillary mobile lymph node level 1 and 2, it's T1 and 1. Number is 2, and this 2 number is for stage 2A. Imagine size of tumor is 5 centimeter. 5 centimeter means T2 and axillary lymph node is involved, N1. So number is 3, it is 2B. And if the size is 5 centimeter, axillary lymph node is matted, so it is T2, N2, number is 4, and the 4 number is used for 3A. So this is how you will remember. It's very, very easy. If you practice, you can easily remember. So that's the staging. You know, whenever we are performing the surgery, most important thing is minimum number of lymph nodes removed for adequate staging, right? And that's why in internship you have seen, आप लोग OT में क्या करते हैं? You are going to label the specimen, you are going to, number the lymph nodes, that how many lymph nodes are removed. This was asked in INI-CET multiple times. And how to remember mnemonic is GB crest. So in gallbladder 6, breast 10, colon rectum 12, esophagus 15, stomach 16. So how to remember, guys? It is GB crest. Mnemonic is GB crest. So I'm repeating. In gallbladder, how many minimum lymph nodes? 6, breast 10, colon rectum 12. This was the question in exam. In carcinoma rectum, minimum number of lymph nodes removed for adequate staging 12, esophagus 15, and you must be knowing for stomach 16. The management of breast cancer is just like mathematics. It depends on the stage. So guys, see, if patient is having early invasive breast cancer, what is the stage? 1, 2A, 2B. And you know that if a patient is having early invasive breast cancer, in majority of cases, we are going for breast conservation surgery. Apart from that, we perform sentinel lymph node biopsy and we give radiotherapy. If there is any contraindication to breast conservation surgery, like pregnancy, in that case, go for simple mastectomy and axillary lymph node sampling. Got it? You remove the specimen, send it to pathology department. After that, you get a confirmed biopsy report. Imagine the size is more than 1 centimeter. Imagine lymph node is positive. Another situation, imagine that size is more than 0.5 centimeter. Lymph node is negative with adverse prognostic factors. And guys, can you tell me what are those adverse prognostic factors? High histological grade, lymphovascular invasion, hormone receptor negative, and ERPR it's positive. So any of these are positive. In those cases, you have to give chemotherapy after surgery. And if you give it after surgery, it's known as adjuvant. If you give it before surgery, that is known as neoadjuvant. So what are the indications of adjuvant chemotherapy? Easy. Next, you can see if a patient is having locally advanced breast cancer, that is known as LABC. LABC, so locally advanced breast cancer, guys, here the stage is 3. What is stage 3? It is 3A, 3B, 3C. 3A, 3B, 3C. And in this case, first downstage the tumor. How? Neoadjuvant chemotherapy and then perform MRM and after that give radiotherapy. So we go for NACT, neoadjuvant chemotherapy plus MRM plus radiotherapy. Clear? And if a patient is having metastatic breast cancer, you know the stage, stage 4. Here, we have to follow two principles mainly. Since patient is already having metastasis, she knows she is having limited life expectancy. So first, prolong the survival and the life which she is having. It means jitna bhi time uske paas bacha hai, what you have to do, improve the quality of life. We give both hormone therapy as well as chemotherapy, but it depends on the indication. If ERPR is positive, there is asymptomatic visceral metastasis, bony or soft tissue metastasis, go for hormone therapy. And when ERPR is negative, just opposite. ERPR is negative, if there is symptomatic visceral metastasis, or if it's hormone refractory. If it's not responding to hormone therapy, hormone refractory, in those cases we are giving chemotherapy. Right? Next, see the management of breast cancer, especially what are the indications of radiotherapy. Ma'am was telling about margin. We people are too much bothered about the margin. Guys, so any patient who is having breast conservation surgery, locally advanced breast cancer, how many lymph nodes are positive? 4 or more, and most important, yes, positive margins. So in all these cases, you have to kill the tumor cells locally, you have to decrease the risk of recurrence, so you have to give radiotherapy. Right? Next, what are the chemotherapy regimens we are giving? We have two regimens. One is CMF and the second is CAF. What is CMF, guys? C cyclophosphamide, M methotrexate. So it is M that is methotrexate. And what is CAF? Cyclophosphamide adriamycin 5-FU. You know that adriamycin, it is also known as doxorubicin, which is anthracycline derivative. We are nowadays not using this methotrexate. So which one is preferred, guys? CAF. How many cycles are given? 6 cycles. You have seen in internship that when a PG or second year PG is giving chemotherapy, before chemotherapy he is going to examine the lesion, document it, and after chemotherapy also he is going to examine and document it. If it is not responding, so it's resistant. So adriamycin resistant breast cancer, we are giving one toxic agent. Toxic, can you tell me the name? Taxanes. And you must be knowing the names of the agent: docetaxel, paclitaxel. So this is docetaxel, and we are giving paclitaxel. Easy. Next, imagine patient is having resistance to both adriamycin also, taxane also. In that case, we are giving ixabepilon. So guys, we are giving ixabepilon. Relatively, it's a new drug. And if patient is having HER2 new positive breast cancer, we give HER. HER means Herceptin. And what is the other name of Herceptin? Trastuzumab. So the first line agent we give Herceptin. HER2 new Herceptin. Herceptin, and the other name is trastuzumab. Trastuzumab. And you know that second line agent, this was asked in INI-CET, that patient who is having HER2 new positive trastuzumab resistant breast cancer, we are giving lapatinib. So the name of agent, it's lapatinib. And suppose patient is having hormone therapy, we have to give hormone therapy. Basic concept is there. Before menopause, premenopausal females, ovary is the main source of estrogen production. After menopause, what happens? There is aromatization. So from adipose tissues, there is production of what? Estrogen. So guys, for premenopausal females, we are giving tamoxifen. That's the drug of choice, tamoxifen. And postmenopausal females, we are giving aromatase inhibitors. Aromatase inhibitors. We are giving aromatase inhibitors. Clear? Tamoxifen, how much is the dose, guys? 10 mg BD for 5 years. So it is 10 mg BD for 5 years, right? Can you give tamoxifen in postmenopausal females? Yes, because this is selective estrogen receptor modulator. We can. But we don't give. Why? Because you know that tamoxifen is having partial agonistic action on endometrium. And that's why there is increased risk of endometrial cancer. So tamoxifen, it's avoided. Why? Because it's going to increase the risk of endometrial cancer. Endometrial cancer. And that's why in postmenopausal females, what we are giving, aromatase inhibitor, you know the name, letrozole and estradiol. So the names are letrozole and anastrozole. So it is letrozole, anastrozole, that's the hormone therapy. Clear? Now over to ma'am.
So like sir was telling us about the hormone status, whenever there is a report, if I have signed out a report and it has gone to sir to follow up with the patient, there are few things which sir is definitely looking out for in that report. It's not just a diagnosis of what the cancer is or what is the type. Have I seen out for lymphovascular invasion? Have I mentioned the Bloom-Richardson score? Have I written the hormone status and also the PTNM that sir was telling? So this is exactly how I do the hormone status testing, which is also known as the molecular classification of breast cancer. And you all know by now it is ER/PR, HER2/neu, on the basis of which we are dividing this into luminal A, luminal B, HER2 rich and triple negative. So imagine if the report says that it's a HER2 rich tumor and HER2 is positive, that is when it sends an indication that yes, we have to give Herceptin or trastuzumab. So this is a constant interaction that has to happen between a pathologist and a surgeon. But now, although today's date, what we are doing for these markers is immunohistochemistry, the brown color stain that I will show you. But back in the day, how this entire classification was made is a previous year NEET and FMG question. It was made after studying a lot of genes. So the basis, if they ask you what is of this classification, is gene expression profiling. But today, what we are doing for these categories is immunohistochemistry. So now let's kind of understand. I'm measuring three things, right? ER, PR, and HER2/neu. If all three come out to be negative, that is known as triple negative breast cancer. If only HER2 comes out to be positive with all the others negative, so common sense tells me that's going to be a HER2 rich breast cancer. And if it's the other way around, see, if HER2 is positive only, it is HER2 rich. But what if ER and PR come out to be positive, then that falls under the category of luminal A and luminal B. And then students ask me that in them, HER2 would be negative. So then they're looking the same, isn't it? Luminal A and B look ER/PR positive. HER2 nu is negative. Can HER2 nu be positive in any of them? Yes. So many a times in some textbooks, luminal B is also said to be a triple positive breast cancer, but not in all cases. But let's assume ER/PR is positive in both and HER2 is negative in both. They are looking the same. How do I differentiate? So there came a marker called Ki-67. If it is less than 14%, we think of luminal A, and more than 14%, we think of luminal B. Instead of Ki-67, if MIB1 labeling index word is written, it means the same. So now your question will be, what are you trying to measure? This is basically telling you the proliferation index of the tumor. So now read it carefully. If the Ki-67 is below 14%, means the proliferation is less. It's a low proliferative tumor. And if the Ki-67 is more than 14%, it's a highly proliferative tumor. Well, that's not the only place in pathology you've read Ki-67. If I remind you of a lymphoma called as Burkitt's lymphoma, you know it is a highly proliferative tumor. So much so that we say the Ki-67 in that nears to be 100%. Which now tells you that, okay, Ki-67 measuring proliferation, that's why Burkitt's is such a highly proliferating tumor. Well, coming back, that is your molecular classification, but all those subtypes that I taught you, how are you going to fit them in? So firstly, in triple negative breast cancer, we have learned NE has all the ME tumors. So medullary carcinoma, metaplastic carcinoma, these are all triple negative. Moving on to HER2 rich, the one that you have to put under this is going to be apocrine carcinoma. And everything else, like a dustbin category or everything else, goes under luminal A. So if you quickly read the good prognosis one, that is tubular carcinoma, mucinous, papillary, and even invasive lobular carcinoma. But can you see I've written low grade? Because this means if it is high grade invasive lobular carcinoma, that will go under luminal B. And that kind of makes sense because luminal A is anyway to do with a low proliferation and luminal B is to do with a higher proliferation, so the low grade and high grade would be distinguished accordingly. But now that you've said that, okay, this is a very textbook thing, is this what I actually do in a laboratory? No. Under the microscope, what I see is this, and I was talking about immunohistochemistry, right? So what is the stain and what is the color that you always get? A brown color, and I've got you 3 representative pictures of each. So, sir, today the report that you see, which is always written as ER/PR, positive or negative, and nowadays many reports do have pictures also, but this is exactly what I'm looking under the microscope. And estrogen receptor, progesterone receptor will always give me a nuclear positivity. So if you look closely over here, it's the nucleus which has come to be brown. It is the nucleus again which is coming out to be brown. So how many cells should be brown that I say that ER is positive or PR is positive? Well, this is a question which has not been asked till now. And I think the upcoming INI-CET could definitely be asking you about the all red scoring, which says that at least even if you see a 1% positivity, you will say that ER and PR are positive. So maybe this fancy scoring name could be a potential question. That's for the ER/PR. What about HER2 nu? You can very well see over here, HER2 nu does not give a nuclear positivity. See, HER2 nu has come out to be brown in the membrane. And that is what I'm looking at when I say HER2 positive. And that report of mine is very important because on the basis of that, the Herceptin therapy will start. So is it 0, 1 plus? What is the scoring like? So a pathologist always also writes 0, 1 plus, 2 plus, 3 plus for HER2 nu, because if I've written 0 and 1 plus, sir will not be starting Herceptin. Reason being, 0 and 1 plus means HER2 nu is not amplified. Don't start the targeted therapy. On the other hand, like this slide over here is fully brown, that is 3 plus, which means HER2 nu is positive, it is amplified. Please start with Herceptin therapy. So I am now stuck in this 2 plus. What if the pathologist's report says HER2 nu 2 plus? Neither is it negative nor is it positive. I call it a state of question mark, which means equivocal, which also means that immunohistochemistry is not the final end of doing HER2 testing. If you get equivocal, now is the time that you go on with assessment of FISH. So this is a question again, that in which case do you go in for FISH analysis when HER2 nu IHC comes out to be 2 plus? So how does FISH look like? I mean, students are pretty scared of such pictures because anyway, a picture of pathology comes up, they have that mental block that हमें नहीं समझ में आएगा. But over here, majority of the work has been done by the examiner. The color coding of fish examiner will have to tell you. Like HER2 new has been labeled as red color, and it's present on chromosome 17, so that is labeled as green color. So all that color coding examiner shall tell you. Let me look at a normal cell. We all know that we have two chromosome 17s as a pair. So I can see two green colors. If there are two 17s, there must be two HER2 news. So I can see two red color signals. I mean, that's a pretty obvious situation. I'll have two chromosomes and I will have two HER2 new genes. But now let's look at this female over here. The chromosome 17s are still two in number like any normal person. But if I count the red color signal, even vaguely counting, I can see there are five HER2 new, which tells me that HER2 new is amplified. Let me look at a third case scenario over here where once again the chromosomes are 17, which are two. I mean, that's obvious, but I can't even count the number of HER2. If I just randomly count, I think because this is done by machines, but if I do it manually, at least 10 HER2 signals are coming, which tells me that HER2 is amplified. So is there a cutoff at 5, 10? When do I say HER2 is amplified? For that, as per the protocol, there is a criteria which says you will calculate HER2 divided by chromosome 17. Let's calculate it. See over here, how many HER2 did I say? I said there were 5 HER2 signals that I got. Divided by chromosome 17, which will always be 2 in any normal person. So this comes out to be 2.5. They say if this crosses 2.2, then HER2 new is amplified, which means you can start with your Herceptin therapy. Over here, there's no need to count. The HER2 signals are 10 divided by 2 chromosome 17s. It comes out to be 5. It is very much amplified, which you can even look and without a formula tell. So coming back, if IHC would have given me a 3 plus, I wouldn't have gone for fish. I would have said it's positive and started Herceptin. But if IHC would have given me 2 plus, then I would have gone for fish. If fish would have told me a signal of more than 2.2, I'll said yes, it's positive. Please go ahead with Herceptin therapy. If fish says it is less than 2.2, I'll say no, it's negative and don't go for Herceptin therapy. So that's a constant interaction that the surgery and the pathology department has. And yes, this is the basis on which finally all of the chemotherapy and all the targeted therapies are started. So now ultimately you realize this is a constant interaction that is happening between the surgeon and the pathologist to come down to a final report on the basis of which the therapy of the patient can be decided.
So, ma'am, I want to ask two questions as an
Yes, sir.
intern and as a postgraduate student also. Because when I was an intern, my PG used to say कि lunch के बाद report लेके आना, biopsy report. और फिर हम लोग जाते थे पैथोलॉजी डिपार्टमेंट में, पता चला रिपोर्ट ही नहीं आई. एंड व्हेन वी यूज्ड टू गो बैक टू द डिपार्टमेंट, ही यूज्ड टू से कि क्यों नहीं लेके आए, एंड वी वर नॉट हैविंग दिस आंसर कि क्यों रेडी नहीं है. सो वी वर हैविंग दिस काइंड ऑफ एक्सपीरियंस कि हमें तो नहीं लगता कि कोई कोऑर्डिनेशन है सर्जरी पैथोलॉजी वालों के बीच में. व्हेन आई वाज एन इंटर्न एंड देन व्हेन
Yes,
आई
sir.
वाज अ
वो I
फर्स्ट
can
ईयर.
understand. That is also because कि सर जब इंटर्न कई बार हमें सैंपल दे के जाते थे तो फॉर्म पे ऊपर द एज वॉज नॉट रिटन, द डिटेल्स, द MRD नंबर वॉज नॉट रिटन. तो पहले तो हमें 1 से 2 दिन इंटर्न को कांटेक्ट करने में लग जाता था कि फर्स्ट गिव अस द डिटेल्स. दे यूज टू राइट अडल्ट फीमेल. आई मीन वी ऑल्सो न्यू कि ब्रेस्ट कैंसर का पेशेंट है, अडल्ट फीमेल ही होगा, बट वी नेवर हैड एनी अदर हिस्ट्री ऑफ हर रिस्क फैक्टर्स. तो पहले तो 1 से 2 दिन हम इंटर्न को ढूंढते थे, फिर हिस्ट्री निकलवाते थे, देन वी यूज टू गिव द रिपोर्ट. एंड दैट इज द रीजन probably which I think every intern will do, and we are all, including myself, guilty of doing this. I believe that could be one reason of the delay.
And the second thing, because whenever we are sending the specimen, sometimes we are having orientation, but pathologists को
हाँ.
orientation नहीं होता था. So they used to say that, please come and discuss.
Yes, sir. I think though there are two sentences. One, come and discuss. Second, please correlate clinically. The pathology department has been famous for these two, and I own up to it because so many times, despite the surgeon putting threads and sutures and labeling the margins, it was very difficult to orient it as per the patient and considering it seriously that if we give a margin positive or negative, it would have an impact. So yeah, there
Right.
were things, and I totally understand कि हम बोल तो देते हैं that there is constant interaction between a surgeon and a pathologist, but actual hospital setting में it is very difficult to even get in touch with the operating surgeon or the reporting histopathologist. So ground reality problems are very different actually from what we are discussing in today's session.
Actually, the people who are suffering, actually, the people who are doing the clerical job means interns
Correct.
and mostly
Interns.
postgraduates,
Yes.
because interns are collecting the reports and postgraduates उनको अपना copy chemo notebook वगैरह prepare करना है. They have to follow up the patient. So sir, this is the main problem we were suffering when we were interns and postgraduate.
So I think that must have got a lot of memories for our students also, because many of them are in internship or have just gotten over with it. So I think, sir, you've opened an entire discussion forum over here. So why not ask you guys also if you have any, experiences of the surgery or pathology department? You can always put it in the comments, and I think we'll also have a good laugh reading them out.
Definitely. So now another important topic is prognostic factors in carcinoma of breast. You know that for most of the malignancies, what is the most important prognostic factor? It is stage. And guys, you know that what are the components of stage? TNM. So most important prognostic factor of most of the malignancies, that is stage, and it is TNM. But there are two exceptions. One is Wilms tumor and the second is soft tissue sarcoma. In Wilms tumor, it's histology followed by stage. So guys, this is histology followed by stage. And in soft tissue sarcoma, it's tumor grade. Soft tissue sarcoma is the tumor grade. Is tumor grade. Easy. Next, what is the single most important prognostic factor in breast cancer? You know, in adenocarcinomas, most common route of spread is lymphatic. So it's the lymph node status. Even in colorectal cancer, that is adenocarcinoma, most important prognostic factor, single most important, that is lymph node status. So here also, single most important prognostic factor in breast cancer, that is axillary lymph node status. This is axillary lymph node status. Lymph node status. And what is the most important prognostic factor in metastatic breast cancer? Metastasis means already it's stage 4. And if it is already stage 4, patient will respond to hormone therapy or she will not respond to hormone therapy. It depends on the ER/PR status, and that is hormone receptor status. So for metastatic breast cancer, this is hormone receptor status. So this is hormone receptor status. Easy. So this is hormone receptor status. That's the most important prognostic factor in metastatic breast cancer. Nowadays, questions are asked about prognostic index. One is Nottingham prognostic index, and guys, the formula is NPI. Nottingham prognostic index is 0.2 into tumor size plus lymph node stage plus tumor grade. So you can see the size, you can see the stage, tumor grade. So why we are calculating this Nottingham prognostic index? To select the patient for adjuvant treatment, whether after surgery this patient requires adjuvant treatment or not. Bloom-Richardson grading, how to remember, guys? Mnemonic is TNM. So T, that is tubule formation. This is tubule formation. N, that is nuclear pleomorphism. N, it's nuclear pleomorphism. Nuclear pleomorphism. And M, that's mitosis. Mitosis. So there are lots of named stagings and grading. If you're talking about another grading which is asked in exam, that is Gleason grading. So if you see in urology, there is Robson staging. What's the name? Robson staging. And you know that this Robson staging, it is used for RCC. Next, there is Jackson staging. Jackson. So Jackson staging, this is for carcinoma penis. So Jackson staging, this is for carcinoma penis, and there is grading, Gleason grading. Gleason grading, and this Gleason grading, it is for CA prostate. CA prostate. So can anybody tell me what is the similarity between all these three stagings and grading for urological malignancy? You can see Sun. So Robson, Jackson, Gleason. So this is the grading and staging which is asked frequently. Another question which is asked frequently, this was asked in NEET PG multiple times, Van Nuys prognostic index. And in one of the latest exam, this question was asked that a patient is having ductal carcinoma in situ. Yes, in which case you are going to give radiotherapy. In majority of cases, lumpectomy is sufficient. But imagine, patient is having positive margins. Patient is having high grade tumor. So in that case, we give radiotherapy also. So this Van Nuys prognostic index, this is VNPI. It is for the patients of DCIS, yes, not requiring radiotherapy. The patients of DCIS not requiring radiotherapy. And you know, आजकल हम सबका स्वागत कैसे करते हैं? आजकल आप सबका स्वागत स्वैग से करते हैं, तो इसका स्वागत कीजिए आप लोग माइक्रो स्वैग से. So this is micro swag. Micro means micro calcification. S, that is size of tumor. W, its width of margin. A, this is age, and G, grade. So guys, this is micro swag, micro calcification, size, width of margin, age, and grade. So this is Van Nuys prognostic index. Now, ma'am will discuss some questions and we are going to discuss the important topics.
So that's been quite an extensive session, which has covered from start to end everything about breast cancer. But there are two questions which we want you also to answer. So it's going to be a give and take, right? The first, like I taught you about MIB1 labeling index, which is for Ki67. I want you to tell me, where do you study MIC2 and what is that a marker of? That's your homework number one. And the second, there is a tumor for which sir was telling us maybe something like popcorn calcification. So now it's the same tumor which also shows you staghorn clusters on FNSE. So you need to put the name of that as well in the comments, and we will be looking out for these answers and monitoring them as well. And as you said, sir, wrapping it up, we have to tell them the potential questions in the last 4 to 5 years across all the exams. And since it is a very surgery heavy topic, I would want you to start and tell them, brief them about what should they be paying more attention on.
So guys, if you have seen the paper, INI-CET, NEET PG, FMG, मैम आप लोगों ने भी देखा होगा पेपर, तो उसमें what we are going to get, एक फिश का क्वेश्चन होता ही होता है, पैथोलॉजी वाला. दूसरा आपका इमेज बेस्ड क्वेश्चन होगा ही होगा, inflammatory breast cancer and purdy orange, and in that case students are confused कि sir purdy orange होगा कि inflammatory breast cancer होगा. So whenever there are signs of inflammation, so you are going to find redness and more than 33% of breast skin is involved, इसका मतलब it's inflammatory breast cancer, otherwise it's purdy orange. Another question जिसमें आप देखते हैं cystosarcoma phyllodes or phyllodes tumor, so that question we are expecting. Apart from malignancy, we are expecting questions from benign conditions like lactating female is there and she is having pain and tenderness, so obviously breast abscess is there, Mondus disease. So these are the potential questions. So important ones: staging, most important, chemotherapy agents, inflammatory breast cancer, purdy orange, cystosarcoma phyllodes, breast abscess. These are the potential questions. इनमें से minimum we are expecting at least 2 in different exams. Ma'am, you also tell
Right.
us.
And to that, I just want to add, like Sir said, phyllodes, that leaf-like arrangement from pathology will always be mentioned. Also, we cannot forget fibroadenoma. It might sound like a very basic thing, but when, like I said, the staghorn clusters or the popcorn calcification, something about fibroadenoma will be mentioned. When it comes to pathology, it's all about the images. Make sure you've gone through the images of the mucinous carcinoma or the lobular carcinoma with regard to the Indian file pattern. So these are the things important. And for INI-CET, don't forget the hormone and the luminal classification that I just now taught you, because there will be a question where they will mention the luminal status and then you'll have to take it further from there with regard to management. So in short, this session has been quite high yield and we have covered most of these that we are telling you to read. So even if you've gone through this, you've in a way covered all the potential questions also. So thank you so much, sir, for such an insightful session. I have learned a lot of surgery today, and the TNM staging, like every student, I have also run away from TNM. So finally, I've learned that 1, 2, 3, 4 trick today. So I think I'll be more sorted now going forward. And thank you so much for all the insight.
Thank you, ma'am. It was differently, a learning session for me also, because we people are not very keen into slides. तो slides वाला
No
part
one
हमें
is, sir.
बिल्कुल समझ में नहीं आता. But
Correct.
yes, I got to understand fish or Fortunio का explanation more deeply today. Thank you.
Thank you. Thank you so much.